Hello everyone, I'm Alan Prost, and I just thought I'd share with you a way to make algorithms to help you with some of your decision-making process for skills testing on week 14. So this is for our first year students in Intervention 1, and I know that from reviewing these online discussions with you, we haven't had a chance to go through as many case studies as I would have liked. So I'm hoping by taking you through this algorithm process, it'll help you with your decision making. And this is an exercise. It's really not to just to copy what I'm doing, but it's to formulate a way that you can approach building your own algorithm so that you're thorough and complete when you're doing your patient assessment and making your decisions for skills evaluation and skills testing. So bear with me and I'll take you through a couple of these algorithms. So this is another example of building an algorithm to help us with our decision making for week 14 and working with ventilated patients. And the question for this algorithm is, should we consider extubating our patient? All right. So we've gone through our overall patient assessment on our ventilator, and we've come up with the idea that maybe we should consider thinking about extubating this patient. So how can I articulate that or go through a clear decision-making tree so it's very, can be really precise in my work? And our first criteria that we're thinking about is, does this patient meet the criteria for spontaneous breathing trial? Now, we want to come back with a simple yes or no for that, but where's the details to determine that? And that's one of the critical things we're looking for. And of course, that comes from our examination of EGANs, all right? When we look at that ventilatory support for spontaneous breathing trials, all right? Obviously, the patient's got to be in a fair amount of low oxygen. They should be stable. No, shouldn't have a significant respiratory acidosis. But one of the most important ones is adequate mentation, all right? So we've got an idea of what the Glasgow Coma scale should be, greater than 13, no, not too much sedation, and that we should be able to have a conversation, and they should be able to breathe reasonably well on their own, all right? So are we seeing some resolution of their disease state? All right, do they have a good effective cough? Right? Those can be very difficult questions to answer. And that's why we do it a spontaneous breathing trial, because we don't know absolutely whether the patient can do these things or not. So we're going to test them. All right. So if the answer to those questions in our details is absolutely no, then we'll just leave them on the ventilatory support. But if the answer is potentially yes, we've got some indication that they're capable of these things. If they haven't been on the ventilator for very long, so less than 72 hours, or they have been on there for a long time, that guides us on how long our spontaneous breathing trial goals should be. All right, and we know with most protocols include a certain level of pressure support, or we can use automatic tubing compensation to alleviate that worker breathing through the endotracheal tube. You'll read about all kinds of other techniques such as a TPEACE trial or CPAP trials, but this is quite commonly used, and I would recommend that for our purposes. I think you should try this. All right, we should have the PEEPs in about levels about 5 or 6. Now we do spontaneous breathing trials on patients who are very critically ill, so it might be higher than that, but we know we're not going to be extubating from those. All right, so let's put them on their spontaneous breathing trial, and let's just see what happens. All right, and our goal now is to decide, do they pass their spontaneous breathing trial or do they fail it? And what's the details to tell us if that's happening or not? And I'm going to come over and refer you back to EGANs again. All right, table 52.6. All right, if their respiratory rate suddenly goes high, then we should probably discontinue that spontaneous breathing trial. But if it's maintained at a relatively normal level, minimal increase, that we don't see a huge increase in worker breathing, if we do, we're going to discontinue our breathing trial. If we see that they suddenly need a high degree of oxygen, if their SATs make a big drop, then we're going to discontinue that breathing trial. But if they can maintain that, then this is good. All right? And this, of course, is where we should discontinue our breathing trial. If we have sudden changes in blood pressure or some of those other, or they become extremely agitated or somnolent, any big changes in mental status would also be a good reason to discontinue that spontaneous breathing trial. All right? When we're doing the spontaneous breathing trial, we often want to know this rapid spontaneous breathing index, where we take the respiratory rate and we divide it by the tidal volume. And remember, that's going to be in liters. All right. So, and that should be less than or equal to that 105. That's kind of the critical number. The lower the number, the better. All right. So when talking a report, these are the kinds of things you want to be looking at to decide whether the patient has passed or failed their spontaneous breathing trial, and you want to be able to articulate that for your evaluator and your colleagues at the hospital. All right. So if they fail the spontaneous breathing trial, we don't have to just abandon and put them back on full ventilatory support. We can augment their inspiratory efforts just by increasing the pressure support. If they can't tolerate that, we may have to go back to their assist control mode or whatever we had, but often we can ventilate the patients quite effectively with just simple pressure support. So that's another part of the trial, and it might be quite high. Often pressure supports of 12 to 14 may be required to support a patient with a fair amount of lung disease. And our goal is to keep their respiratory rate less than 20. So if we fail, we've got our decision-making tree. Now what about if they pass? Now if they pass and it's been a couple of hours, so greater than 120 minutes, you might put them on back onto or increase their pressure support level to support them until we've made the decision whether or not we could extubate them. All right? But there's some more information we need if we're going to think about extubating that patient. All right? So if we're thinking about extubation, we really need to know a little bit more information. And one of the tests we can do is that vital capacity maneuver. And that should definitely be greater than or at least equal to that 15 mils per kilogram. So how do we do this test? We get the patient to take a big breath in as big as they can. Big, 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 and blow it out, blow it out, blow it out. And we just read the VT off the ventilator. All right? And let's say that might be 2.2 liters, something like that. And then we're going to divide that by their ideal body weight, and that'll give us their mils per kilogram. And that's an important piece of information that many clinicians would want to know before they're thinking about extubating a patient. All right. Another thing we're going to be thinking about is, do they have a leak past that endotracheal tube cuff? So we should be decreasing the, just very quickly, put your stethoscope by the patient's throat, decrease the pressure in the cuff and decrease the cuff pressures until we hear that little leak. If the answer to that is no, that's going to be an important piece of information. So if the answer to both of these questions is yes, that we have a cuff leak and they have a good vital capacity, then we can go ahead and suggest possible extubation. Now, many clinicians are going to be involved and make sure we've got the resolution of disease process. All right, so make sure that the patient's actually ready, and that's usually a group decision. If the answer is no, there's no leak past the endotracheal tube cuff, or they have a really poor vital capacity, then we should considering keeping them supported on the ventilator until they've got resolution of this problem. And it might just mean that we need further consultation with other experts in the team, such as the physician. All right. So where do we get some of these numbers, like this vital capacity? All right, and I'm going to come back to our Egan's tables here, 15.2, where it shows us what kind of our basic kind of settings to be potentially successful at extubating our patient. They should be on a low amount of oxygen, should be on relatively low amounts of PEEP, all right? That we should be able to maintain their SATs in around that 90%. And we should see things like their CO2 within a fairly normal range, maintaining a reasonable pH, all right? And this is where we're going to do that rapid, or that spontaneous breathing index, all right? And that should be less than or equal to that 105, all right? Make sure you report that out. Here's where we wanted to make sure that our vital capacities are adequate, all right? We often might not know their static compliance, but sometimes we can, and that should be fairly high, greater than 25 according to here, all right? We should have a reasonable level of minute ventilation. Somebody's got really high minute ventilation, probably can't be extubated. And their work of breathing should look to be reasonable, and obviously they can maintain it. All right? So that comes back, and this is some of the details to support your construction of your algorithm. And that's really what I wanted you today. I don't want you to copy my algorithm. I want you to be thinking about building your own. And I think this will help you solidify the decision-making trees in your own mind and remind you as you go through that what details and what information you need to consider making decisions at the bedside. Thank you very much.